Good evening, everybody. I'd like to extend a very warm welcome to this evening's meeting, Medicine for Members, the Royal Free London, in partnership with DeepMind. My name is Jude Bailey, and I'm privileged to be one of your public governors. I recently retired from the Trust as a senior midwife, having worked across the 3 sites, and during that time I also served as a staff governor. I personally am very excited about the collaborative work with clinicians and DeepMind to improve the clinical outcomes for our patients. Before we start, a couple of housekeeping points. We aren't expecting any testing of the fire alarm system. However, if there is one that goes on that is a continuous fire alarm, then we would have to leave. And there are 2 doors at the back, but that's most people at the front, so it's the doors on the left and on the right. The loos are just out of here, turn right, down the corridor, and they're on the right-hand side. I would like to welcome our panel this evening. Dr. Jenny Cross, sorry Jenny, consultant nephrologist and clinical director for nephrology at the UCL, and Dr. Dominic King, who is the clinical lead for DeepMind, and Tosh Mondal, who is the Deputy Chief Information Officer and Head of IT Infrastructure at the Royal Free London. After the presentations have finished, there will be time for Q&A, and I ask you to be kind enough to leave questions until that point in time. If there are any members of the media, could you please be kind enough to let yourself that you are here, be known to a member of staff. So Ian Lloyd, one of our communications team, is here. Any media questions should be raised via the communications team. So without any further delay, I would like to ask Jenny to start the presentations.
Thank you. So I am a working nephrologist, so I'm a kidney specialist. And when you get kidney failure of a low degree or a high degree, you would come and see me or one of my team. Now, for the purposes of this presentation, what I'm thinking of is perhaps not what you're thinking of. Most of kidney disease is about chronic kidney disease that comes over a long time. And what I'm thinking of in this presentation is people who are unfortunate enough to get really sick really quickly and develop acute kidney trouble as part of a much bigger, serious illness. I want to talk a little bit about what we've been doing over the last couple of years in partnership with DeepMind, like one of our many other partners that we have in the NHS, to try to use modern technologies to improve the delivery of healthcare in real time. So we're going to move through the talk in this way. We're going to describe the technologies that we could use and the advantages that has for improving patient care. We're going to tell you about a very particular type of app or application, a program that we've used to try and help us to identify sick patients much earlier, to use those golden hours at the beginning of their illness really effectively, so we can get them better quicker to make their outcomes better. And we're going to talk a little bit, moving on to Dr. Dom King from DeepMind, how patients and the public can help and become involved in this kind of work. And I'm going to talk a little bit with Dominic King about the sorts of technologies that we might have for the future. Who in the room in the last 24 hours has used a smartphone, a computer at your home, at your desk, or a laptop, or an iPad? Hands up. Okay, so I can see you all. It's the vast majority. There's 2 or 3 people out of the whole audience who haven't used a smartphone. This is what it looks like on the train. Everybody's got one. Everybody uses one. They're easy, they're intuitive, they help because it makes it easier to get to some of the stuff that you want to access quickly. Why wouldn't we use that in healthcare if we use it in everything else? Why wouldn't we try to? So NHS hospitals have, I think traditionally, and I've had a lovely conversation with the gentleman in the front row here, about his experience of what we've got in the NHS, which is one of our systems is called Cerner, and he tells me that he received 6 letters about his ophthalmology appointment in Barnet. The technologies that we have in many ways are excellent, and many other ways just don't fit together because there are 16 or 17 systems that don't talk to each other. And we've all had the experience of things just not fitting together when you come and see the doctor, in primary care with your GP, or in the hospital, or with your specialist on a different site, seeing a hospital doctor in Royal Free, seeing a different doctor in Barnet, and being told that the Royal Free doctor can't see the Barnet doctor's results. How frustrating is that for all of us? What a waste of time, and the point that you made, what a waste of money. The way that we currently work with our systems, with our pagers, with our telephones, logging on to slow computers on our desks, having to leave the patient in the ward round to look for test results and then go back to the patient means that our processes slow down our ability to give patients quick, accurate, high-quality care, in my view. And I think this is definitely a view shared by the kidney team at the Royal Free, who also provide kidney services on all of our other sites around the north central London sector. So that's Barnet, Edgware, the North Middlesex, University College London Hospital, and the Royal Free, some of which are specialist hospitals. So I want you to imagine a scenario, because I think it's most useful to think about what this actually means for people in clinical practice. So scenario 1. 25-year-old man, just completed university, let's call him Tom. He suddenly becomes unwell after falling over in his garden onto a spike. He thinks it's nothing. He's got no problems with his health in the past. He leaves it for 2 or 3 days, and he progressively becomes unwell with fever, a fast heartbeat, breathlessness, and eventually, at his mother's insistence, he's brought to the emergency department. The emergency department junior doctor sees him. Not a huge amount of experience, but he knows what he needs to do. So he puts a line in, he tries to get some fluid in, but he doesn't know how fast to give it. He takes the blood tests, he sends them off to the laboratory, the patient goes to the ward. A new team takes over. The junior doctor is called back about the results from the laboratory. They're very, very abnormal. They're seriously abnormal. He's very worried about the patient. But he's got a whole emergency department full of patients, and the patient's gone to the ward. So he telephones the person who's looking after the patient now. He can't get hold of them because that person's looking after somebody else. He leaves a message for the nurse in charge who speaks to the doctor. By this time, 2.5 hours has passed. Eventually, we have a kidney problem identified, we have inadequate fluid resuscitation, and we eventually have the consultant called, and he said, it's clearly an emergency, get the emergency intensive care team down, let's get this thing sorted. We all arrive on the ward en masse, and we aggressively treat the patient. The tragedy is that the senior members of that team sometimes come to this sort of scenario, a young, fit, healthy person, where we've used 2 or 3 or 4 of those hours processing through our processes. And we get to the bedside and we know that things have gone too far, and whatever we do, we think we're going to have a bad outcome. And many, many times our intensive care colleagues have said that it is unbearable to get to the bedside of a patient knowing that there were subtle signs of the problem very early on, like their kidney function going off, and people didn't realise the significance of it. And 4 hours later, it became absolutely apparent how important that was. Imagine a different scenario, that we have some technology that takes out the human factor of passing complex information between teams in an organisation that employs 10,000 people. Imagine we had it on a smartphone in the back pocket, where all of the results are integrated together, and we get alerts to say, I think this person's got acute kidney trouble. Not only are you looking at the result, but you're looking at the synthesis of the result, what it means. You miss out the block from casualty to the ward. You don't have to ring the nurse because the consultant on call in kidney medicine is alerted. He's never seen the patient before. He doesn't know the patient exists, either at his home or on the ward. He will receive an alert on his phone as if you got a ping from your bank. or a text from your daughter, or an alert from The Guardian saying that Putin's done something new. There's a headline that focuses your attention on a critically unwell patient in the trust that you previously wouldn't have heard about until 4 hours later. Those are a golden 4 hours. They're the kind of 4 hours that change a young person's response to sepsis or acute kidney failure very markedly. It can be the difference between surviving and not surviving. It can be the difference between going to an intensive care unit or not going to an intensive care unit. The Royal Free is privileged and lucky enough to have been chosen to be a global digital exemplar. And what that means is that we're given £10 million by NHS England to develop technologies and digital services for the improvement of patient care. What does that mean? What do we want to use that £10 million to do? Well, we would like to stop having variations in the way that we manage patients. If we find a brilliant way to treat something, if that's the best way, everybody in all of our hospitals should receive the best treatment, not variations on a theme in different hospitals. That improves outcome and it improves patient experience. We aspire, and we're on track for, having the first completely digital hospital on the Chase Farm side. Everything digital. We hope to be able to implement population health, and that is trying to do something preventative, not reacting when it happens, but doing something about it before it happens by trying to coherently integrate, to sensibly put together what your GP's doing with what we're doing, so that we've got some memory of what happened to you in the 20 years before patients ever came to the hospital, which is, of course, the majority of their life, because people don't spend necessarily long times in hospital or lengthy periods in hospital. We want to give our staff time to clever things that reduce the waste of time that we have entering data, trying to find data, trying to manipulate data. If there's a clever way to do it, give it to us. We're young, we use these all the time in our normal lives. We would like to use them for patient care because they work well, and for most people, they're fairly intuitive. It's not just about hospitals. I alluded to this earlier. We could use it for primary care, even in your own home. Anybody check their blood pressure at home? Anybody regulate what their exercise does? Anybody look at the health app on their iPhone with the heart on it, where it counts your steps? All of those things could be used as part of your healthcare, because we should be able to perhaps in the future import it into your healthcare. If you record your blood pressure on your iPhone, we could Bluetooth it into your health record. There's many examples of how we could utilize this sort of technology to make it easier for all of us. Some people have said that hospitals operate in an island. It's the NHS. But of course, the NHS is absolutely not an island. There are hundreds of examples where the NHS partner with industry in order to get the best that technology has to offer for patient benefit. So examples of that are companies like Baxter Healthcare. That's a private company. They produce all the fluids that we give in hospital and the dialysis stuff we give in hospital. Fresenius, they're a multi-billion-dollar company. They produce machines that we do use on intensive care units. And finally, things like CT scanners. Philips, they make your radios. They make your radio alarms, make various other things, headphones, and they make CT scanners. And we buy their CT scanners because they're very good. Sorry. Of course, drug companies. That's another private and NHS partnership. We can't do without them. We use them all the time. We're constantly in partnership with industry. So after that, I think that's all I've got to say. Thank you for your attention. I'd like to hand over to Dominic King, who is one of the clinical senior advisors for DeepMind, who'll tell you a little bit about the technical aspects of the app that we use.
Great, thank you, Dr. Cross. Very honoured to be here today. Firstly, because we're really proud of the partnership we have with the Royal Free. Secondly, because I live around the corner, and so I care as much about this hospital is, as you guys do. Actually, my 2-year-old son has been admitted here 3 times in the last year. So I'm expecting social services to knock on our door any time soon and take him away. But he's received very amazing care here. So for that too, I'm really honoured to be here. So before joining DeepMind 2 years ago, I worked actually at Imperial College at St Mary's Hospital in Paddington for about 12, 13 years. I was a general surgeon. And I also had a deep research interest in patient safety. So I spent many years researching why, as Dr. Cross said, why patients deteriorate, how many patients deteriorate, and what kind of interventions we can do to make sure patients receive really the best possible care. And the reason I joined DeepMind a couple of years ago was because I was really excited about the potential for the technologies they were building to really transform healthcare delivery. So I'm not sure if many of you are familiar with DeepMind, so just to give you a little bit of background. So DeepMind is a very proudly British company. It was founded by 3 Londoners and is widely considered to be the leading kind of advanced technology company, advanced artificial intelligence company in the world. So we say it joined forces rather than was acquired by Google back in 2014. The reason we say that is because all the decisions we take are in London, not in California. The founders of DeepMind remain in charge of it now. 2 North London founders who take all the decisions about what areas we work in, who we partner with. It's grown massively. When I joined DeepMind 2 years ago, there's about 200 people there. There's now 800 people who work in King's Cross. And it's widely considered, as I said, to be the greatest concentration of artificial intelligence talent anywhere in the world. And I personally think it's a great thing that that's taking place in London. We do have, in the last year, we have opened offices in Canada and in the US, but 98% of our staff are based in London. And it's a very diverse group of people. About 2/3 of that 800 people have PhDs. We come from 40 or 50 different countries. We have dozens of professors, neuroscientists, mathematicians, physicists, computer scientists, and engineers, all working on these technologies. So DeepMind itself is broadly split into 2 groups. We have about 2/3 of the team working on research, trying to progress the kind of field of artificial intelligence. And then I sit in a team that looks about how we apply advanced technologies to areas that we think are really important. And the most important area we think is in healthcare. So lots of people talk about artificial intelligence. I want to be very clear right at the beginning. What we're doing at the Royal Free does not involve any artificial intelligence. It doesn't involve any robots or anything that would cause you guys any concern. I think there's huge potential for artificial intelligence in healthcare, and I'll give you some examples of why. But hopefully by the end of this presentation, you'll get a very clear sense of what we're doing in partnership with the Royal Free and why it doesn't involve artificial intelligence now. But that will become clear, hopefully, by the end of this presentation. But what is artificial intelligence? Lots of people talk about it. This is the kind of wiki definition. Computer systems to now have been pretty stupid. Okay, they do what we tell them to do, and this sense that they're in any way human has not, it's just not been the reality. And when we talk about artificial intelligence, what we're talking about is can computer systems demonstrate the ingenuity of people sitting in this room? Can they do things like translate? Can they look at pictures and tell what something is? Can they make a decision based on very complex data without the input of human experts? And there's many types of artificial intelligence, and I'm just going to give you the 2 types of, describe to you the 2 types of artificial intelligence we use at DeepMind. So it's pretty remarkable that 10 years ago, a computer system on its own was unable to tell the difference in a picture between a cat and a dog. That's something my 2-year-old son who keeps hitting his head and falling over is able to do, and probably has been able to do, not far off his first birthday. But the advanced computer systems, these like huge supercomputers, weren't able to do that. And that's because what we actually do, how humans think and perceive, is actually like remarkable, and we're nowhere close, like computer systems are just nowhere close to matching our abilities. But what we're seeing with something called deep learning, which is a type of artificial intelligence, is that we can kind of start recreating how neurons in the brain work. And actually, about 10 years ago, someone published a paper that said, actually, we can tell like the difference between a cat and a dog. And so if you go into your Photos apps on your phone, whether you have an Apple device or a Google device, your photo system will now start dividing your photos up and start saying, oh, this is holidays, this is your pet cat. And we're starting to see this intelligence being implemented into these systems. The other thing is something called reinforcement learning, which again, like children learn through trial and error. And computer systems now are starting to learn through similar processes, like what gives them the biggest reward for the least possible input. And DeepMind actually became famous 4 or 5 years ago, and that's what led to their move and the acquisition from Google on this piece of work, which this system, this algorithm that I'm showing you, some of you will remember this computer game Breakout. When the algorithm first started playing the game, it was pretty useless. Like if we started playing it, we'd be like this, not really knowing its way around the game. And after about 300 games, it got as good as anyone in this room. So it's getting the ball back, it's breaking the wall down, and the arcade score is going up. It's not been trained how to do anything. And as myth has it, the engineers went home and left it playing overnight. And when they came back the next day, after it played 500 games, the algorithm had learned through trial and error this way of playing the game that really boosted the score up and caused it the least amount of work possible. So this is what we mean by reinforcement learning. Now, when you join these things together, you start getting some really like powerful impact. So for those people that have worked in academia in the room, Nature is the world's leading academic journal. This is the types of journal that people spend their whole academic careers, the whole labs working towards getting one paper here. And DeepMind have been really successful at publishing lots of papers in Nature. So the Atari game, the work we did on that was published a couple of years ago. There's an ancient Chinese game called Go, which is much more complex than chess. When we beat the world champion of Go last year, which was another Nature paper, we showed that computer systems can develop memory, which was another Nature paper. And then earlier this year, we showed that these systems could play chess better than any system that had ever existed before, and also could start learning and playing things without any human training at all. So I just want to give you the science of artificial intelligence is really progressing at like enormous pace. And we're starting to see this technology being deployed in the real world. So on the kind of, as Jenny described, the devices that all of us are using every day. So the ability to translate maps, speech, if you have Alexa at home or Siri on your phone, all this is now being driven by this type of artificial intelligence. And this type of artificial intelligence is also opening up new opportunities. Now, that may be things like autonomous vehicles. Like, this is all being driven by this type of approach. Now, what I'm really interested in and passionate about, I'm not an artificial intelligence researcher. I'm interested about, could we take some of this technology and deploy it in like our hospitals? Could it help doctors and nurses and patients prevent the types of deterioration or accidents that we see all over the hospital? And that's why we set up DeepMind Health. And we think at points in the future, the types of technology I showed you will have an impact. They will help us diagnose disease earlier on x-rays. They will help us pick up the patient that needs urgent attention of Dr. Cross or her colleagues. But there's a lot of work to be done to get there. So I just want to quickly talk about our research projects, because this is very separate, but kind of confuses some people about what we're doing. Are we doing a research project at the Royal Free? Is there some artificial intelligence work going on here? The answer is no. We are doing artificial intelligence research in healthcare. We have a project with Moorfields Eye Hospital looking at eye scans. Those of you that are diabetic or have had any visual problems, you may have had retinal scans. They're very complex to look at, and I'll show you some of the results of that. We're looking at radiotherapy planning at UCLH. So if you have a head and neck cancer, it can take a radiotherapist up to 8 hours to carefully segment the scan that plans your radiotherapy, and we're helping the radiotherapists see if these artificial intelligence approaches can help with that. And we're working with Imperial College London looking at mammography. Just quickly on the ophthalmology work, 2 million fellow Brits have sight loss. Much of it's entirely preventable. Diabetic retinopathy, changes, age-related macular degeneration. These scans are like beautiful images that you get of the back of the eye now, but they're really difficult for experts to interpret. And there's really lengthy delays in people getting treatment. Now, what we're seeing in our work at Moorfields is that the top row is what the ophthalmologist sees. The middle row is what the world's leading expert ophthalmologists at Moorfields. This is areas that they segment out, draw around, which are areas that they're really worried about. These things need urgent treatment, or this patient's going to go blind or get sight loss. And what we're finding with our artificial intelligence is that we can pick these areas up just as well, maybe better, than people that have been doing this for 20 years. So we think, we'll be publishing the results of this soon, but we think that this type of technology, particularly in medical imaging, can be really beneficial. But in the world which Dr. Cross described, where doctors and nurses are still using pagers, they're still using pager lists, we're still using fax machines. The Royal Free uses technology in a much more sophisticated way and advanced way than many NHS hospitals, but it's still common to see lots of paper around, paper charts. The idea that you can use advanced artificial intelligence in this type of environment is just actually not realistic. And so we think a really important first step is to help use our expertise to help hospitals like the Royal Free, and we're also working with a number of other NHS hospitals, to move away from a technology at pagers that were invented 50 years ago and are not used in any other industry apart from healthcare. I should say this is not an NHS problem. I was actually in the US just on Monday. If you go to the leading hospitals all over the world, including the Royal Free, this is what you see in pretty much every leading healthcare provider. We just haven't moved the needle as much as we should in terms of enabling technology. So our partnership at the Royal Free began 3 years ago, and it's interesting, I think, to talk through how that started. So I'm not sure how many of you have heard of acute kidney injury. It's a really serious problem. It kills 40,000 people a year. It's not just in the UK, in England. And a quarter of that's entirely preventable. So just to be clear, 10,000 people a year is estimated at least die from acute kidney injury every year. That is way more than die in car crashes. And there are ways, if you have an acute kidney injury, you want to, Dr. Cross to come and see you and sort you out and get home safely. Now, Chris Lang, who is one of the other nephrologists here, actually approached DeepMind a couple of years ago. And there's an existing alert in the NHS which is used to try and flag patients with acute kidney injury. And Chris had seen some of the work DeepMind had done and said, surely you guys, the current alert works if one of your just one blood test goes up, an alert is flagged to Dr. Cross or colleagues. And Chris said, look, if you guys can do this amazing stuff with Go and Atari games, surely you can come up with a better algorithm for identifying acute kidney injury at an earlier stage, because you only currently get a flag or an alert when a lot of your kidney is already injured. And our team spent a lot of time at the Royal Free, and we're very confident that we can come up with a better alert. In fact, we're working on that in a separate project research project, and we're very confident that we are going to come up with a better alert for acute kidney injury. The problem is that on the top half, if you're in a world of pagers and fax machines and phone calls, it takes ages for anyone to respond to that alert. I'm not saying all the time, some people, and I'm not talking specifically about the raw free, but there's lots of delays in the process. So we think it's much more important that we sort this top problem out, and that this is the basis of this Streams app, before we start thinking about what's the role of artificial intelligence in acute kidney injury. So just to kind of be clear about what Streams is a secure mobile app. So it sits on smartphones. It's like the apps that many of you use for all kinds of other reasons. And the aim of it is to give Dr. Cross and colleagues the right information at the right time about the right patient. There are, in every hospital in the world, limited numbers of clinicians, and particularly really expert consultants and professors. And if you're the most unwell patient in the hospital, you need to be seen by that expert. And this technology allows alerts to be sent to Dr. Cross and colleagues about the patients that they most need to see. Now, Streams does lots of things for clinicians. So you have to either be a clinician or follow them around to understand how difficult it is at the moment. You're logging in and out of different systems. The vital signs, your heart rate and blood pressure, is on a piece of paper at the end of the bed. Your blood tests are in one electronic system. If you want to look at an X-ray, it's in another system. So that can take 10, 15 minutes. You're unwell, and the nurse pages the doctor. Sometimes that takes 10 minutes for the doctor to come. They then need to spend 20 minutes looking after your medical record. What we're able to do is within seconds, the clinician can look, they can see all your past medical problems, they can see your vital signs, they can see your heart rate, and so vital signs, heart rate and blood pressure, your blood tests. At the moment at the Raw Free, we're really looking specifically at blood tests, but also radiology reports, what X-rays you've had done, what microbiology tests. And we're starting to see signs of really tremendous impact here. So previously, it would have taken many hours, if you had a severe acute kidney injury, many hours for Dr. Cross to come and see you, because for her to come and see you would be dependent on one of the junior doctors and another team recognizing a problem, often starting initial treatment, then paging Dr. Cross's team. Then Dr. Cross's team may have then escalated to Dr. Cross and said, I think you really need to come and see this patient. Now this can take many hours. What we're seeing with Streams is that this is over the course of 6 months, that we've identified thousands of acute kidney injuries just in this hospital, and this is a very busy hospital and a very big nephrology unit, but it's taking a median time, an average time of about 12 minutes for someone like Dr. Cross or whoever's on call, a specialist, to see that alert when it would have, I think, conservatively taken many hours. And I think this is a really positive thing that, over the last 6 months, 1,300 bedside reviews have been done by the nephrology team. Now, many of them will have happened anyway, but I think we can all say that they've been, almost every single one of them will have been speeded up because of this process. In February of last year, the Evening Standard published a story of this lady who had a cesarean section at the Raw Free. She developed sepsis and acute kidney injury immediately afterward, well, not immediately afterwards, shortly afterwards. And, the specialist team here was seeing her almost immediately as soon as those blood results were back. Now, they would have seen her at some point, but as Dr. Cross said, that 10 minutes or that hour can make all the difference between someone needing dialysis for life or ending up in an intensive care unit, or unfortunately sometimes even worse. Now, I just to go a bit off piste for a minute, I absolutely think, and we're committed to providing this type of technology to patients and the public. My son, the 2-year-old, is very well now, but he was born prematurely, and we spent many weeks and weeks in hospital and many months afterwards going to lots of appointments. it's really frustrating if I can change a flight or change a restaurant reservation or message my relatives in Australia that I can't do the same in healthcare. I can't look at when my next appointment is. I can't change it easily. If I have a blood test, I'd quite like to see that evening and not wait 4 days to find out what it is. You know, we have a very, I'm sure, tailored group of patients here, but most of you would want access to this information. If you're using wearable data, you would like that in your medical record. You would like to be able to communicate directly and securely with your clinicians. So I absolutely think this technology should be being provided also at some point to patients. That's ultimately a decision, obviously, for their hospitals and trusts and the patients that they're looking after. Just where is the AI? At some point, we think that, you know, as our algorithms get to a standard where we can deploy them, that, you know, if we're able to pick up on an X-ray, which we are already, or some of our colleagues, that someone's got pneumonia, as we're able to summarize a medical record for a discharge letter, as we have better alerts, that we are now able to surface that within streams. And that's ultimately where we want to get to, but is absolutely not what we're doing now, and is not part of any contract or part of the current partnership agreement. That would only come in future if we thought that was or the trust thought that was a sensible thing to do. Now, many of you will be familiar with some of the headlines. I can say from my clinical perspective and my involvement at the Royal Free, I think what we're doing is an absolutely transformative project, and I think it is going to deliver really major improvements to patient care. But it has been controversial in a number of ways, and I'm sure we'll talk about this on the panel. And I think, you know, there's positives and negatives to any type of partnership, as most of us know. And I think we need to reflect on some of the lessons that we've learned. For me, the most important of those lessons is that it's incredibly important that the patients who we're here to serve and the clinicians we're here to serve are aware of how their data is being used and processed. So if you go onto the Royal Free website now, you'll see an amazing video and information about how data is generally used at the Royal Free. As Jenny said, lots of different providers are essentially using data to try and help deliver better care. So I think there's lots more information now available about how your data is actually being used, and I think that's incredibly important. From DeepMind's perspective, you know, most of us are academics. Most of the senior team at DeepMind are clinicians and academics. We are really committed to publishing what we do and showing that we're having impact. So everything that we do is published and will be published. All our contracts are made transparently available. This is very kind of strange for most commercial companies. You can go onto the DeepMind website, go to the Royal Free part of that website and download the full contract describing what the partnership does. So we think it's really important that we're as transparent as possible with patients and the public about the work we're doing. And I just want to point out, you know, really strongly say a few things. The Royal Free is in charge of patient data in this organization. They decide, all the companies that Jenny described, the Royal Free decides how and whose data they process, and we are one of many different processors. So we will only ever use that data for the purposes in which the Royal Free want us to, and that's substantiated in legal contracts. These contracts do not allow any type of AI research. They do not allow any type of things for us to do outside of the contract. It's for the delivery of streams. You know, people worry, oh, are we mixing this with your Gmail, or are we doing targeting advertising because we now have health data? That is absolutely not the case. It would be illegal and absolutely not something we would do. So, you know, this is all very formally done in legal contracts, but is also the approach to how data is used is very important to us from an ethical standpoint. We've spent the last year speaking to lots of groups like this, patient groups, patient representatives. On Friday, we actually had, last Friday, we had 12 patients that came in, visited our office, had lunch with our team. Any of you would be welcome to join the next event, and please come up and ask me, and I'll put you in touch with the right people. It's really important to us, as I said, that we're working with you to deliver this technology. So this was an event we ran a couple of months ago where we brought lots of patients and the public together and asked them, like, how should a technology company like DeepMind work with hospitals and with patients? And in doing so, came up with a list of principles and approaches which we're very committed to following, being transparent about the work we're doing, solving problems that are important to you guys, measuring impact, publishing results, working towards social good, making sure that data is safe and secure, and really collaborating with the amazing experts that we do at the Raw Free and other partners. So I think I have a couple of minutes left. So I'm going to, so Jenny talked through what does patient care look like if you get all this technology right. So I'm just going to go back to, I'm going to call him Robert. So let's imagine Robert, young guy, has poorly controlled diabetes, and he collapses at home and hits his head. Now already there's technologies, I have an Apple Watch, but there's already technologies that many of us use that are very soon, if not already, able to pick up strange things in your behavior. So if you're an epileptic, you have an epileptic fit. If you're a diabetic and you're usually at work during the day and suddenly you're on the floor at home and you're not getting up, an alert could be sent to either your family or a clinician to say, this is a bit strange, Robert should actually be playing football now. He should be at school or university, and an alert sent to a physician. So if that alert's going to be sent to a GP, for example, it's very useful for this GP, Dr. Jones, who gets the alert to be able to, like, she may never have met, we've all experienced going to see the GP who's never met you, the emergency GP. She's never met Robert before, but she's now able to look at his medical history, his vital signs, his last blood glucose, to see, is this abnormal for Robert? Is there something strange here that I should be worried about? He's hit his head, he's not responsive, so she knows that this isn't something that can probably be managed in the community. So she can make sure that Robert's admitted to the right hospital. Again, many of us have had frustrating times when we go to a hospital and you find that they don't have the specific speciality, so you're waiting for hours and hours to be transferred to another hospital. As soon as Robert arrives in the hospital, the right doctor gets an alert. If any of you have experienced being in the emergency department waiting hours to be seen, sometimes that's because the charge nurse is paging lots of different teams to find out who the right doctor is that should be coming down. But this could be intelligently done through alerts like this. As Robert goes to see, as this doctor gets the alert, she's got lots of things going on. She's got loads of patients to see, but because Robert's unwell, his care is prioritized over other patients in the hospital. When this doctor goes to see Robert, again, how frustrating is it when the doctor is constantly writing notes or in front of their computer and not looking you in the eye? Actually, if any of you use it, on your smartphone is great voice recording technology. These consultations are recorded, they're in the medical record. If you have any questions and you want to hear the consultation later that evening because you've forgotten what was said, you have access to it. But these kind of consultations can be recorded. Robert's hit his head, the doctor wants to order a CT scan. There's probably at least 15, 20 people in this hospital who are all waiting for a CT scan tonight. Those CT scans should be prioritized, and Robert's scan is prioritized given his clinical deterioration. There's not always a neuroradiologist available to look at a scan, so there may be an imaging algorithm that's able to look at that scan and say, actually, there's a bleed here, this needs urgent attention. Robert goes to operating theatre, imaging and control software guides his operation. This stuff is already happening all over the place. It's just not really joined up in the right way. As many of us have had operations, as you make your recovery, you develop a temperature, you start becoming unwell. Rather than those temperatures and heart rate rises being put onto a paper chart, they're put into an electronic system. It automatically recommends a chest x-ray. The chest x-ray is done. The chest x-ray picks up a subtle pneumonia. We know from recent research that artificial intelligence approaches are picking up pneumonia more sensitively now on x-ray than radiologists. So now Robert's getting a diagnosis way quicker than he previously would have done. He's getting his antibiotics, he's getting treatment. And so, you know, he makes a good recovery, he's ready to go home. And like, what happens when you're ready to go home in hospital? Well, you're going to stay here for another 12 hours because someone needs to do your discharge paperwork and get your medications ready. A lot of this could be automated. So we can create automatic discharge letters and summaries, coding already. As Robert leaves the hospital, his GP has pinged a message to say Robert's leaving so that care is nicely joined up. You know, maybe a bit far-fetched, but again, like, what keeps you in the hospital for 6 hours? The hospital transport needs to take you home. You know, there are other approaches that could speed things up for people in this room. And importantly, Robert's making a recovery at home. He's able to track his progress. If he has a question, have you ever been there where you have your question and you have to ring up the, you know, hospital, the switchboard, you get through to the consultant secretary, say I've got a question about my operation or whether I need to come back in, and you can spend hours and hours in that process. Why shouldn't, like, most of us as clinicians would be quite happy, I think, in a secure way to be able to message and chat with patients who have questions? It would save everyone time. And most importantly, Robert is measuring his blood glucose anyway. He's managing his own illness. He's, you know, young, intelligent. And in future, he may get a prompt to say, actually, you're developing hypoglycemias. Why don't you change your insulin? This whole episode of care should have been prevented in the first place by Robert changing his medications. And so the kind of sense of, like, as Jenny said, like, working on more preventative care rather than reactive, I think is becoming the new paradigm in reality. So hopefully that gives you a sense. This is like the nirvana that every hospital in the world wants and every health system wants to get to. But I, like, genuinely think that the Raw Free is as well placed as anywhere for this to happen. And the success of this is not dependent on DeepMind. It's dependent on largely the Raw Free and also lots of different partners, of which we are one. We think we can provide some useful solutions, but there's the need for lots and lots of different providers and partners to make that a reality and hopefully improve care for all of us. So on that note, thank you very much, and I think we're open to any questions you have.